Good morning, everybody, and big warm welcome to the first of the second semester collaborative teaching, urology teaching. And we've got two important talks this morning. The second talk will be from one of our rising stars in the Division of Urology at the University of Cape Town, Dr. Nkanyezi Sigaza. And she's going to be dealing with an important core topic, how to manage recurrent urinary tract infections. But we're going to start off today with the lead clinician at our combined uro-oncology once a week meeting, Dr. Santuri Viranna, and she's a clinical radiation oncologist. And she is going to be talking to us about the primary and recurrent staging of using PSMA scanning for prostate cancer. So I think this is, again, a very important topic, so something that certainly is going to come increasingly up in the exams and in our clinical practice. So Santuri, thank you very much for making the time, and we're looking forward to your talk very much.
Okay, thank you, Prof. Good morning, everybody. I hope you can see my screen and hear me well.
We hear you fantastic. That's good. And your slides are now maximized. That's fantastic. Thank you.
Okay. All right. So thank you for the introduction, Prof. Today, I'm going to be talking about a very important and interesting topic relating to staging in prostate cancer in the era of PSMA. And this is from an oncology perspective. So an overview of my talk, it's going to be just going through an overview of imaging in prostate cancer, specifically focusing on PSMA PET and the evidence behind it. And then just to talk about some of the clinical implications of using this type of imaging, how it affects our clinical decision-making, and lastly, just to share our experience at CRISCare so far. So imaging in prostate cancer is an area that is rapidly evolving from conventional imaging, which refers to the use of ultrasound, CT, and bone scan, to next generation imaging, which includes the use of MRI and PET imaging. So in terms of conventional imaging and bone scan, so bone scan is really quite an old technique. It's been around since the 60s, but it is still the most widely used method of detecting bone metastases. It has limited sensitivity and specificity, but the diagnostic yield is dependent on a number of factors. So the positive predictive value of bone scan depends on the PSA level being more than 20, the clinical stage, so whether the patient has palpable disease, the ISUP tumor grade, and also whether patients are symptomatic. In terms of CT, CT has a relatively modest sensitivity in detecting bone metastases. And this is because there needs to be quite significant bone destruction or new bone formation before lesions are detectable. In terms of nodal staging, sensitivity is only around 42%. And this is because CT relies mainly on the size of the node as well as abnormal morphology, but cannot detect mets in normal sized glands. But despite these obvious limitations of conventional imaging, there are important advantages that need to be acknowledged. So firstly, these tests are widely available, they are affordable, but most importantly, we have decades of experience using them, and they are incorporated into clinical trials and guidelines. But let's look at the road ahead, and the future of imaging is most certainly in the direction of PSMA PET. So what is PSMA? PSMA is a protein that is expressed on the surface of prostate cells. It is overexpressed 100 to 1,000-fold in prostate cancer. And this expression is further increased in tumors that are metastatic or have become castrate resistant. PSMA gets labeled with radioisotopes such as gallium-68, which emit positron radiation that gets picked up by the PET camera. What we're going to talk about today is how PSMA-based imaging outperforms standard imaging, both in terms of specificity and sensitivity. It's been approved by the FDA in December of 2020 and is really emerging as the most promising target for prostate cancer, not only for imaging, but for therapy as well. So when is PSMA PET recommended? So we're going to talk about these three situations: primary staging, in biochemical recurrence, and then in advanced disease. So let's start with primary staging. So who needs metastatic screening in prostate cancer? So these are the NCCN American guidelines. And you can see that it's the unfavorable intermediate risk, high and very high risk patients that require bone and soft tissue imaging. And this is in keeping with the EUA recommendations. So the evidence for using PSMA PET in primary staging comes from the PRO-PSMA trial, which is an Australian trial that was published in the Lancet Oncology in 2020. And the aim of the trial was to compare accuracy between PSMA PET and conventional imaging in high-risk prostate cancer. So they randomized just over 300 patients to both CT and bone scan and PSMA PET, and found that PSMA PET has superior accuracy, so 92 versus 65%, has greater impact on treatment and treatment change, so 28 versus 15%, and results in fewer uncertain results. They also noted that PSMA PET has almost less than half the radiation exposure compared to conventional imaging. So this is the study that supports the use of PSMA PET as a suitable replacement to conventional imaging. However, what the study did not report on is how the information gained from using PSMA PET and the subsequent changes in management influenced outcomes and survival. So that is an important limitation of the study that needs to be acknowledged. In terms of nodal staging, so there have been several prospective studies that have looked at staging accuracy for detecting lymph nodes with a PSMA PET. Essentially, PSMA PET has a high specificity rate of over 90%, but limited sensitivity of only around 41%, meaning that it can miss small pelvic lymph nodes. And so if you have a negative PET, this does not indicate that a pelvic lymph node dissection is not required. So currently, PET imaging cannot replace doing a diagnostic pelvic lymph node dissection. What about whole body MRI? So whole body MRI has been shown to be more sensitive and specific than conventional imaging in detecting metastases. We know that it has the advantage of diffusion weighted imaging. But compared to PET-CT, PET has actually been found to have a higher sensitivity for detecting both bone and nodal mets, with no difference in specificity. So what do the guidelines say? So the EUA guidelines, they clearly acknowledge that PSMA PET is more accurate for staging than conventional imaging, but state that currently no outcome data exists to inform subsequent management. So it is a strong recommendation, but so is conventional imaging. What do the American guidelines say? So NCCN says that PSMA PET can be considered as an alternative to standard imaging. ASCO's approach is to start with conventional imaging and only in negative or equivocal cases to consider next generation imaging. So essentially, the summary is that yes, PSMA PET is more accurate, but prospective data is limited in the primary staging setting. Now let's look at biochemical recurrence. So PET imaging has been extensively studied in this setting for a very long time. Currently, there are 5 PET traces that are FDA approved. But imaging in biochemical recurrence is actually only of value if it leads to a treatment change. So there have been multiple studies done in the setting. And essentially, what we know about PSMA PET is that it's able to, there's a high detection rate at a low PSA level, that sensitivity increases with PSA levels. And in patients who have histological correlation or imaging correlation, there is a high positive predictive value. So this was a meta-analysis done that included over 37 articles with over 4,000 patients, and collectively showed that positive scans increased with higher PSA levels. So from the table, you can appreciate that at relatively low PSA levels of between 0.2 and 0.5, you actually get quite a high detection rate using a gallium PSMA PET. So let's look at the guidelines. So the EUA guidelines, strongly recommend the use of PSMA PET as well as other isotopes with PET for patients that are fit to undergo curative salvage treatment. This is quite similar to the ASCO recommendations, both in the setting of patients that have had prior surgery or prior radiotherapy. And they recommend that when your next generation imaging is positive, that one should always consider biopsy of accessible lesions. So what are some of the limitations of PSMA? You can get false negatives. So some tumors have absent or low PSMA expression. And these are generally tumors that have lower Gleason grades, very dedifferentiated tumors or neuroendocrine tumors. And in these particular tumors, it is suggested that there is a complementary role for the use of an FDG PET. So the tumor may not express PSMA, but will have high metabolic activity on an FDG. And then very small tumors that are below the detection of the PET camera can be missed. You can get false positives. So you can see uptake in ganglia, which can sometimes mimic nodal mets. Certain benign disorders, such as fibrous dysplasia, Paget's disease, schwannomas and meningiomas. And then other tumors, so renal cell carcinoma, hepatocellular carcinoma, breast and lung cancer. And then there's the obvious limitations, cost and availability can be limiting depending where you work. So let's talk a bit about some of the clinical implications in using this type of imaging as it relates to primary staging as well as oligorecurrent prostate cancer. So if you have a conventionally imaged patient that's M0, they will have certain treatment options such as surgery or external beam radiotherapy. But we know that if we do a PSMA PET on these patients, there is a percentage of patients that will actually end up being low volume M1, which has a different set of treatment options. So here you'd want to use, ADT and also consider possibly irradiating the primary. But the question is, what is the ideal? Because all the trials that have been done that have looked at irradiating the primary have been based on conventional imaging. Similarly, you could have a patient who's imaged conventionally as low volume M1, and the PSMA PET will reveal that this patient is actually high volume M1. And here, the addition of chemotherapy becomes an important consideration. So these are kind of some of the situations that you face, and is the reason why a lot of oncologists still prefer using conventional imaging in primary staging to guide treatment decisions. So this brings us to an important concept known as the Will-Rogers paradox or Will-Rogers phenomenon. So you have two sets of patients, essentially, your early stage and then late stage patients. What PSMA PET is doing is identifying a subset of the early stage group and calling them late stage. So by removing this group of patients from early stage, this is seen as an improving prognosis for early stage disease. And in terms of late stage, this subset of patients have a lower burden of disease than the very late stage. So you also see an improving prognosis for late stage patients. So this is a kind of stage migration, which does have implications on management, because there is a risk of over-treating patients, which is an important concept to be aware of. So another area that PET imaging has kind of identified is, the area of oligometastatic disease. So what is the definition of oligometastatic disease? So there's no consensus on the exact definition, but essentially it is a patient who's got limited systemic disease, generally between 3 to 5 metastatic sites. And there are 3 clinical scenarios of oligometastatic disease. The first is a patient who is de novo oligometastatic, meaning upfront staging, the patient has limited volume of metastases. The next scenario is a patient who's got oligometastatic recurrence. So this is someone who's had their primary treated with radiation or surgery, and then develops biochemical recurrence. And when you image those patients, they have limited number of metastases. The third setting is the setting of oligometastatic progression. So this is a patient who is on ADT, who may or may not have had their primary treated, who then develops progression in only a few lesions while on ADT. And there are currently 2 important questions that are being asked in the oligometastatic setting. The first is whether we should treat the primary, so that is in the de novo metastatic patient, with the hypothesis being that by having a controlled primary, you may delay seeding of resistant clones. And the second question is in the setting of oligometastatic recurrence and the concept of metastasis-directed therapy. But all these discussions about metastatic disease actually revolve around imaging. So if you use standard imaging, you're only seeing the tip of the iceberg. But as you go down and use more sophisticated techniques, you actually get to understand the true nature of the disease and see the disease from a completely different perspective. And I think it's important to remember that there's a lot about the biology of prostate cancer that we are still learning. So just to talk a bit about radiotherapy to the primary. So all I want to say here is that there is level 1 evidence for irradiating the primary in metastatic prostate cancer. And this comes from 2 trials, the Dutch HORAD trial and the Stampede trial. Both these trials showed in the subgroup analysis that there was a survival benefit for patients who had limited number of metastases. So that was defined by the charted criteria in the STAMPEDE, and it was in patients who had less than 5 mets in the HORAD trial. And essentially, there was a meta-analysis done by the StopCap consortium that pulled the results of both these trials, and essentially concluded that there is about a 7% improvement in 3-year survival in men who have fewer than 5 bone metastases. What about metastasis-directed therapy? So metastasis-directed therapy is in the setting of oligometastatic recurrence. So a person who has biochemical recurrence who has 3 or less metastatic sites. And the hypothesis is that by eradicating or treating these oligometastatic disease with radiotherapy or surgery, you may delay, the need for initiation of ADT and potentially improve disease-free survival and or overall survival. So currently, there have been 2 trials. They are phase 2 trials that have looked at, metastasis-directed therapy for prostate cancer, and have compared observation versus stereotactic ablative radiotherapy. And essentially, both show that there is longer ADT-free survival and improved progression-free survival with the use of metastasis-directed therapy. But, the data is still early and still limited, and it's not without toxicity. So currently, it is only recommended in clinical trials. Okay, and then just to mention briefly advanced disease. So in advanced disease, the theranostic principle becomes important, which is the concept of treating what you see. So we know that in the castrate-resistant setting, we have data that has shown that the use of lutetium therapy does improve overall survival for patients who have metastatic castrate-resistant prostate cancer. And, we use PET imaging not only for treatment, but also for assessing response to therapy. So what do we do at Critiskia? So our protocol for staging. So for high risk and high to intermediate risk patients, we use technetium labeled PSMA, which is a Hynek scan for patients that are fit for radical treatment. The use of a gallium PSMA PET is used in primary staging, but only when Hynek is not available. And we use it in the setting of biochemical recurrence in patients that are fit to undergo salvage treatment. So just to mention a bit about Hynek PSMA or technetium labeled PSMA, this was a study done by colleagues in Pretoria. It was a small study, but essentially wanted to compare the diagnostic sensitivity of a Hynek and a gallium PSMA PET. And they showed that a Hynek actually is able to detect up to 78% of lesions that are detected on a gallium-68 PET. One of the limitations of a Hynek is that it uses a SPECT CT system, which has a lower resolution than a PET-CT. And so it has a lower ability to detect small volume disease. So it can miss small lesions. So just to lastly end off with some of our experience at Critiskia. So in terms of primary staging, we've certainly seen that PSMA imaging reveals disease well beyond the classic pelvic lymph node dissection and radiotherapy treatment fields. this is an example of one of our patients who had a high neck, who you can see has extensive nodal burden and nodal disease up the para-aortic chain. And this has resulted and impacted our management decisions. Sometimes it affects our treatment intent, where we may choose to change from radical to palliative. Sometimes the modality of treatment that we choose to use. Currently, the most recent recommendation is that for radiotherapy, one should include the common iliac lymph nodes in your elective nodal field, which is something that we are starting to do. And then we also have, in selected cases, irradiated the primary in patients that have low volume metastatic disease upfront. In the setting of biochemical recurrence, it's been very helpful identifying patients for salvage therapy. But I think one of the challenges we face is when we pick up oligomets, in the recurrent setting, and how do you treat these patients? Do you offer them permanent ADT? In some patients, in selected cases, we have, sometimes opted to offer intermittent ADT. But this is a difficult area, I think, to treat and needs to be individualized. But the greatest benefit that we've seen has been in the advanced disease setting. So, in the state sector, we are limited by the number of treatment options we have for our patients. But, PSMA imaging has helped us identify the patients who have high volume metastatic disease. And, there is a survival benefit for offering docetaxel with ADT in the metastatic setting. So we've been giving a lot more docetaxel upfront. And then in the castrate-resistant setting, we also have been able to identify the patients that are fit for lutetium therapy. So this is a picture of one of our patients who had castrate-resistant prostate cancer. You can see his PSMA PET. He's got extensive bone metastases. And he was actually referred on for lutetium therapy and had a great response. So just to end off with some take-home messages, PSMA PET is an important pillar guiding prostate cancer care. Better detection rates and change of management does not necessarily mean better clinical outcomes. This is an area that we still need more data on. And in terms of decision-making, I think it's critical to always work as a team and make decisions together and make the best decision for the patient as a team. In the setting of recurrent oligometastatic disease, currently only level 2 evidence supporting metastasis-directed therapy. And essentially, we still need much evidence to guide clinical decisions in response to what we find on imaging. So thank you very much for listening. I just wanted to acknowledge my team that I work with at Ali 34. So I work with Prof. Lazarus and Sam. We're very lucky to have strong nuclear medicine input from Dr. Stuart Moore and Dr. Justin Peterser. We have radiology that joins our meeting, and of course, the great Greg Hart when he's able to join. So thank you very much.
Santuri, thank you for a great talk, such exceptional clarity in terms of this topic, and I'm sure it's helped colleagues around the country to understand better this new disruptive technology. There's also a proudly South African component, of course, with a nuclear physician from Pretoria, Mike Sitake, who has replaced lutetium with actinium as a potential castrate-resistant therapy. So that's quite nice. I see Cleve Oppel has his hand up. Cleve has been doing an MMed on PSMA. Let's hear your question, Cleve.
Thanks, Prof. Good morning. Thanks, Sam, for excellent talk. Just want to know, in the staging setting, at Hrudisky, we currently use bone scan, and then if that's clearly sort of negative, we offer patients a PSMA SPECT, and then a gallium, especially if the PSMA SPECT is equivocal. I know there's obviously quite a big cost difference between gallium, PSMA, and bone scan, and the availability of gallium. We don't always have that available. Patients have to go to Tygerberg for that. But because of sort of PSMA's sort of superiority compared to a bone scan and the difference in cost, should we be offering these patients bone scans at all? Or should we just sort of offer them an upfront PSMA SPECT scan instead?
Hi, Cleve. Thanks for a great question. So yes, this is definitely something we actually have looked at, and is something that we've, amended in our protocol. For patients that are fit up front, we've actually now stopped doing bone scans and actually go straight to a Heineck PSMA, because we do feel it's more cost efficient. It's only in the patients that, we are unsure whether they will be fit for radical therapy, who we actually start with the bone scan first, because if that picks up metastases, then, it's a cost saving method as well. In terms of resources. So that's something that we have changed. And then in patients, like you said, if we have equivocal findings on a Heineck, then we do, in selected patients, then opt to do a gallium PET. But that's kind of a case-by-case discussion with nuclear medicine. So that's kind of the direction we've been going in.
Thanks very much.
Thank you, Santeri. We have a question from our colleague from Port Elizabeth, Dr. Kohli.
Thank you so much, Prof. Lazarus, and I hope everybody can hear me. I'm on the road. I just want a comment, maybe. Thank you very much, by the way, for the talk, Dr. Viranna. I just wanted a comment from Dr. Viranna about what she would say to somebody who says they only make decisions about treatment for a prostate cancer patient based only on bone scan. I mean, there's clearly a whole lot more information available about a variety of other, I think, process disruptors. But I mean, if somebody said to you, for them, they do a bone scan and from there decide on managing a patient, what would your comment be in the current context of all the other available information? Thanks.
Thank you for that question. So I think it depends on the risk category of the patient. It depends on what your intention of treatment is always before you decide on how aggressive you're going to be in terms of staging. So if it's a fit patient who requires, like I showed, all high tier intermediate risk and high risk patients require not only bone imaging, but soft tissue imaging, because you need to pick up, nodal and visceral metastases. So, my comment would be that if you are going to do a bone scan and you do not have PSMA imaging available, one should at least do a CT scan with a bone scan before making a decision. But obviously, if you have access to PSMA-based imaging, that would be the way to go, because it offers you both bone and soft tissue imaging, and is more sensitive and specific. I think only in the setting where you have a patient who's got a limited life expectancy, a poor performance status, and you're working in a resource limited environment, would doing a bone scan alone maybe be considered reasonable. But I think in all other cases, it does depend on what you have available, what you have accessible. Obviously, a bone scan plus a CT is better than nothing, to make an informed decision.
Santeri, maybe I can extend Dr. Kohli's question by saying that I think this goes to the Will Rogers phenomena, doesn't it? That potentially with this new technology, we're going to be picking up more metastases and may, in our mind, reduce the number of patients who are suitable for radical care. And that obviously is a change in the way that we've been thinking about these patients. They would have 5 years ago simply gone on to a radical radiation. How do you view that playing out?
Yeah, so I think that is a challenge. I think it depends on what you have available to treat patients. That's an important consideration because, you know, doing tests and not being able to offer, you know, a treatment option once you find those, you know, if you find metastases, it becomes challenging. So I think it does depend on your availability, not only of imaging that you have, but you know the treatment modalities you are able to offer the patient. You know, so that's why in the setting of biochemical recurrence, if you're not able to offer salvage therapy, you know, one should think whether you should be imaging patients if it's not going to change your outcome.
Yeah. I'm just going to move to a question from Dr. Sawley Mink in the chat. He's saying, in the setting of oligometastatic disease recurrence, is stereotactic radiation can be given? Does that mean you don't have to give ADT?
So this is a very interesting question. So they are looking, where ADT is important is in oligometastatic nodal recurrence. So there have been phase 2 trials that are looking at whether you should irradiate the node, give whole pelvic or elective nodal radiation, but they have included ADT. So kind of short-term ADT in those trials. So I think that is an area that is, you know, developing, and I'm sure there will be more information soon, but currently it's very limited data on that.
I got a sense from those 2 papers that you quoted that maybe the ADT was in fact delayed in that setting, and that's what they were looking as one of their outcome markers.
Yes, sorry, in those trials, yes. I was talking specifically about nodal oligometastatic recurrence, but in the 2 trials that I mentioned, the Oriole trial and I think it's a Storm trial, they did delay ADT. But, you know, eventually the patients do need ADT at some point. But in those particular trials, ADT was not given.
Sure. I'm just looking if there are any more hands for Dr. Viranna, any more questions? I think we don't have any more and we're on time. Santuri, I just want to thank you on behalf of all of the people watching. I think it's been a wonderful start to our 2nd semester, and thank you so much for taking the time.